Okay, so um, for the first question on the homework, it said, what does MAC stand for and what is the definition? So MAC is minimum alveolar concentration, and it's the concentration or percent of an agent where 50% of patients will not respond to a painful stimulus. That definition was in the handout, that inhalant summary handout, also in your book. And what does MAC tell me about my agent? MAC tells me how potent my agent is. It's like if you have a very potent agent, it doesn't take as much of it to cause the same effect. Now, remember, MAC or potency doesn't tell me how fast it works, because, for example, when you compare the MAC values, which I will skip down on this sheet for a second. For number 8, since we're talking about MAC, it says, what are the MAC values for the following agents? And sorry, it should have said for the canine, but that's what I wanted you to know. If you look on this inhalant summary, sorry, let me zoom this in a second. Okay, if I go down here, halothane MAC is 0.76, ISO is 1.2, SIBO's 2.1, and I don't think I put methoxyfluorine, but it should be, I think it was like 0.45. I have to double check. You actually didn't need to know methoxyfluorine for the test, as far as its MAC value. Just know that it's an older agent, and I'll kind of talk about that. So again, this is telling you that, to understand it, is if you had 10 dogs and you gave them, I'll use ISO, if you gave them 1.2% ISO, then 50% of them would react, meaning 5 of them, and then 5 of them would not react to a painful stimulus. But again, MAC doesn't take into account other drugs. That's only that drug. So whenever, we have other, and it's very rare that you would only use an inhalant in a patient. Every once in a while, in practice, you might mask something down to take out, like sometimes they have sutures near their eye, or they have sutures near like their prepuce, or maybe a sensitive location. And, sometimes animals, they don't want you to touch, there to take, out the stitches. So sometimes you might mask something down just to do something very brief, but it's rare that you would use the inhalant as your only agent. So you have to realize when we give other agents, part of the justification for pre-meds and induction is its MAC sparing effects, meaning you should be able to use less drug, less anesthetic gas in your patient. So that's kind of the real world example of, MAC. Okay. Now why won't this go away? Okay, let me open this back up, sorry. My computer is really testing my patience. Okay, so MAC tells you how potent, and then what does blood gas partition or blood gas solubility tell me about my agent? Blood gas solubility tells you speed of induction. So, for example, you either have an agent with a high blood gas solubility or an agent with a low blood gas solubility. The lower the gas solubility, the faster the induction. So what solubility means is when an animal inhales the agent, when they inhale isoflurane, it's got to diffuse from the alveoli in the lungs into the capillaries, into the blood. Once the drug hits the blood, the molecule, if it's lowly soluble, if it has a low solubility, means it doesn't want to dissolve into like the tissues or the compartments. So if you think about it's got to travel from the blood to the lungs, get all the way to the brain. If it starts to absorb into the tissues and if it starts to absorb in the plastic, when it gets to the brain, you don't have a high enough concentration. If you have an agent that has a low solubility, it stays intact as a molecule. It doesn't diffuse into the tissues and the plastic as readily. So therefore, it stays intact within the blood and it makes it to the brain more readily. So, for example, a a blood gas solubility is going to really give me an idea of how fast I can expect the patient to become anesthetized. So for number 4, which is a faster induction agent one with a higher low solubility, you should have put low solubility. The lower the solubility, the faster the induction. It remains intact in the blood. It makes it to the brain, produces anesthesia. So if I'm comparing, the lowest solubility agent we have is sevoflurane. The next lowest solubility is isoflurane. Both iso and sevo are fast. Sevo is faster. That also means quicker recovery. That also means a quicker change in plane. So when you make changes during surgery, when you turn them from like 2% to 1%, they're going to change. You're going to see changes more rapidly in your patient with sevo, pretty quick with iso, and then halothane took longer to change. So, the problem with halothane, and let me explain briefly, halothane has a higher blood gas solubility, and halothane does, when it gets into the blood, it starts to move into the tissues, it gets absorbed some in the plastic. So the problem is it took a longer time to get a high enough concentration in the brain. And then when you turn off the agent, it has to leave the brain, but it also has to leave the tissues, and some of it comes out of the plastic. So you have this, it takes longer also to change planes during the procedure. If you want to go from like 2% to 1%, it's going to take a little bit longer for you to see an effect. And the effect is our heart rate coming up, is blood pressure coming up, are we starting to see a change in reflexes and such. So if you have any questions, please bop in if there's something you're not understanding, because those concepts are not always just easy to absorb. Sometimes, because let me give you an example. Sevoflurane has the lowest blood gas solubility, but the highest MAC. So you can see right there is that the low solubility means it's quick induction, but it has a higher MAC, because MAC is just telling me it's not as potent as, say, halothane, but it still works faster than halothane. So again, those things mean different things about the agents. What is the difference between a precision and a non-precision vaporizer? Which do we currently use in veterinary medicine? So this is a broad question, but if you remember, a precision vaporizer is temperature controlled and it delivers a consistent percent. So when you put a number 2 on the dial, that is 2% isoflurane going to your patient. And the precision vaporizer, what you want to also note on here, a precision vaporizer means vaporizer out of circuit. So remember, the vaporizer notes are in the PowerPoint I loaded under inhalants. It's equipment, and I told you the number of the slide yesterday, but a precision vaporizer is also known as a vaporizer out of circuit. So what that means is that you set the dial, you set a percent, and then it is connected via a tube to deliver to the breathing system, which is the circle or the circuit, but it's outside of the circuit. So if a patient changes their respiratory rate, doesn't matter, and you're delivering a consistent percent. Now, currently, a non-precision vaporizer is kind of a jar and a wick, and it is also called a vaporizer in circuit. So you do not have as much control when you use a non-precision vaporizer or a VIC. Because if you remember from the lecture, and if you weren't in class, you need to make sure you watch that video because I explained all of this. There was a jar with a wick and it's attached within the circuit. So if your animal, say, went from 10 breaths a minute to 20 breaths a minute, they're going to pull more air through that jar and wick. The patient could affect its own concentration. There's a little open close valve that would open and close that, but you don't have as fine control as you do with, and obviously precision means precise. Non-precision, you kind of open it, you read your effects of your patient, and you kind of have to play with that a little bit. So, and again, the key here is the current agents that we use are called volatile anesthetics. Isoflurane and sevoflurane are considered volatile, and volatile needs precise control, and it means they have a high vapor pressure. They want to turn to a vapor very quickly, and we have to control the rate of vaporization, because we don't want the patient to get too much. So the vaporizer in circuit, or the non-precision vaporizer, was designed for the older anesthetics we don't use anymore. So it's not appropriate to use that type. And I doubt that any of you will see it. There probably, just as I'm going to say it now, there's probably going to be a picture of that vaporizer. We talked about the parts on the vaporizer, or kind of I talked about the vaporizer. So make sure you review that we talked about in the PowerPoint. And so I kind of just explained number 6. If an agent is volatile, what does that mean? So the volatility means it typically has a high vapor pressure. So high vapor pressure anesthetics are considered volatile anesthetics. And just meaning they're hard to control. You have to control the rate of vaporization. And that's going, remember, they're liquid, but they have to be delivered via a vapor. And I don't know if I have it on this slide, but it said, what was I just going to say? Oh, the carrier gas. So they have to be delivered to the patient. Oxygen is currently our delivery gas, and that's the oxygen delivers the vapor to the patient. So they're not going to just inhale the vapor by itself. It has to be delivered via a carrier gas, which we use oxygen. What are 3 common side effects of halogenated agents? So all of the agents in general, number 1 are respiratory depressant. And this, you see this in the notes, it says dose dependent. And what that means is obviously the higher the dose, the worse the respiratory depression. So they're going to, and respiratory depression can mean rate and depth. So they don't breathe as often, they don't breathe as deep. They are a cardiovascular depressant. Now they have minimal effects on the cardiovascular system overall. They're considered fairly safe, but the problem is when you start getting above 2.5, and like SIVO 4%, when you start getting above 2.5% ISO, maybe 4% SIVO, you're going to see more of these side effects, worse respiratory depression. They are potent vasodilators. So, you can see hypotension. You can see lower blood pressure, which I told you guys, what do? If they're hypotensive, I try to turn down my agent. I try to give them a fluid bolus. You also may want to give them another analgesic, because remember, these aren't analgesic. And so if they're feeling or reacting to something, you need to turn them down. You may need to give them something for the pain. For the CNS depression, the only thing you can do is try to turn them down. They don't cause seizures. So only one agent sensitizes the heart to arrhythmias. That was halothane. So in that case, I wouldn't use halothane if I had a patient that had seizures. Because it can make, arrhythmias, because if they have arrhythmias, it can make it, potentially, could make the arrhythmia worse, and we wouldn't want that. The other thing I want to say is ISO and SIBO require very, very, very minimal hepatic or renal metabolism, liver or kidney. So they were safe. If you did halothane, that did get metabolized within the liver and kidney. So you may want to choose another agent. I just gave you the MAC values. For number 9, how do pre-meds affect the MAC in your surgical patient? It lowers the MAC. They are called MAC sparing. So theoretically, you should be able to use, if I compare a patient, if I have 2 dogs, one gets a pre-med and one gets nothing. Technically, the dog that has pre-meds, you should be able to use less of a percent, and that's your MAC. So MAC sparing is one of the justifications to give pre-meds to every patient. That's a benefit. So MAC sparing. For number 10, can you reverse inhalants? What do you do in the event of an overdose? The inhalants are not reversible, okay? The nice thing about inhalants, especially ISO and SIBO, which is what you guys will use, is, if we have an overdose, which maybe you turn them up and you turn them up for too long, is immediately turn them off and increase your oxygen delivery. Meaning, sometimes I'll turn up my flow meter. Sometimes I haven't talked about the flush valve yet on an anesthetic machine, but there's a button called the flush valve. And the flush valve, when you hit it, delivers a burst of of oxygen only into your system. It bypasses the vaporizer. So if I have a patient that I'm really concerned, I'm like, oh my gosh, we're heading towards potential CPR, or, I really don't like it. Sometimes I'll turn off the anesthetic. Sometimes I'll dramatically, and when I say dramatically turn it down, I've turned patients to 0.5% that have maybe been at 1.5 or 2%, so it's a pretty rapid turn down. But the thing to remember is to increase the oxygen delivery. And what oxygen will do, it'll dilute out the anesthetic. Okay, so if I turn down inhalant, increase oxygen, and then if I bag my patient with that higher oxygen concentration, it's going to dilute out, and then that causes them to release the anesthetic and hopefully exhale more than they have inhaled, and it dilutes it out. Now, an overdose, I didn't give you much information there. If their blood pressure was low, you could do a fluid bolus. Maybe they're severely bradycardic. Maybe you have to give them atropine. But in the meantime, if you treat with atropine and you give a fluid bolus, or say you try to reverse dexdomitor because that's on board, you still have to turn down your inhalant and dilute out your inhalant. Okay. I will tell you, as a practical tip, if we have a patient that's in trouble, like impending cardiac arrest, or they really bottom out during anesthesia, one of the first things we do they have reversible drugs on board? These are not reversible, but if they had a dexdomitor pre-med, we might, if I'm concerned, I'm going to try to take away any drug I can. So a lot of times, sometimes we do reverse dexdomitor while turning them down, turning up the oxygen, giving fluid. So, but in this scenario, I just want you to know, if for some reason you left them turned up too long, or someone turned them up, the way to wake them up from the inhalants is to increase your oxygen delivery to dilute out your anesthetic gas. And you can sometimes, depending on the patient, but usually within about 3 to 5 minutes, you should see some changes, because again, ISO and SIBO are pretty rapid recovery. How do we achieve anesthesia with inhalant agents? Explain the process using physiology. Well, basically what happens is they inhale the drug, which is being delivered via oxygen. The inhalant diffuses from the alveoli into the blood. The blood carries it to the brain. Now, the fact that these agents are lipophilic, and the brain is a very fatty tissue, enhances that uptake. It's a like environment. So when they're being carried in the blood, the brain kind of acts like a sponge because it's lipophilic. The drug is lipophilic. It soaks up that anesthetic, and then the anesthetic depresses neuron function, and we produce anesthesia. Now, inhalants are not sedatives. If you tell me on a test that it gets uptaken, if it gets uptaken and then the patient becomes sedate, that's wrong. These are general anesthetics, and they're meant to keep the patient asleep. So it causes CNS depression. So we've got muscle relaxation, and we have, they're unaware of their surroundings. They are anesthetized. Once you turn off the agent, and now you just have oxygen going to your patient, then what's going to happen is that concentration gradient, remember things move high to low, you had a high concentration in the brain, you've turned it off, so you have a low concentration now in the blood. It's going to move to the blood, which is going to go back to the lungs, and the patient exhales the agent. And that's how they recover, is they have to exhale. Like I said, it's a very tiny, tiny amount that does go through the liver and kidney, but nothing of the majority of recovery from these agents is exhalation. They have to exhale it to get rid of it. So if you have questions about number 11, or just stop me if it's not making sense. The color codes, isoflurane is purple, sevoflurane is yellow, and halothane is red. So the bottles and the vaporizers are color coded. And again, these agents are not interchangeable in the vaporizer. ISO goes in an ISO vaporizer, Sevo and Sevo. You will damage a vaporizer if you put the wrong agent in it, and you can kill a patient if you just decide, oh, well, no big deal, I'll just go ahead and use it anyway. Because they have specific vapor pressures, specific temperature controls that control the amount of agent. And so you turn that on, you just kind of have no idea what you're delivering to your patient. So if you make them, there is a way to drain the vaporizer. So if you put the wrong agent in, it can be drained and essentially drained out. But like I said, a lot of times you'll end up getting it serviced to make sure it's cleaned properly. But you can drain an agent if you accidentally put one in. For 13 is nitrous oxide an inhalant like sevoflurane? Explain. Nitrous oxide is a medical gas. It is used for its analgesic effects. It produces a state of euphoria, but we do not use it as the sole agent in veterinary medicine. Like I said, if you go to the dentist, a lot of people will get nitrous, get that little mask. I do it because I have a big fear of the dentist. So I get nitrous, and you feel kind of, I mean, I still, I still get my jaw numbed. I mean, you'd have to get numbing. It's not going to be enough. You will feel some sensation. And veterinary medicine is used as an adjunct. So it can be added into an inhalant protocol to enhance analgesia, and it'll lower, like if I used nitrous with isoflurane, first of all, isoflurane needs oxygen. So I would have a flow meter delivering oxygen through my vaporizer. There would be a splitter, and there would be a separate tank and a line that would add in nitrous to the gas mix. So I don't use it, but again, nitrous oxide competes for oxygen, especially in air spaces. So when nitrous diffuses in the body, it likes to go to air pockets. One thing that, it was contraindicated if you had a GDV. If you had a dog with a bloat and that stomach is filling with gas, and you gave nitrous to your patient, it would gravitate to that stomach and could swell the stomach even further. So it competes for air spaces. Now, the problem is, if I'm giving it with oxygen, I always just have to make sure my oxygen is at a higher percentage or a higher flow than my nitrous, to make sure that it didn't displace the oxygen. But I just want you to know it's primarily nitrous oxide. It's not a general anesthetic, okay? It's used to enhance analgesia. It'll enhance the sedative effects of the agent, but we kind of use it in conjunction with a primary inhalant. And 14, what is the carrier gas for inhalant anesthetics? And that is oxygen. So that's what we currently, sometimes people get confused and they think, oh, we're we're going to use nitrous oxide. Nitrous oxide isn't a carrier gas. It's not what we use for a carrier gas. And oxygen, excuse me, is what carries the inhalant. Okay, are there any questions about those questions? Okay, let me get to, here we go. Let me just review this, oopsie. Why does my computer hate me? Why do you hate me so much? Okay, open on the right side. There we go. All right, let me pull up the picture of the vaporizer to just kind of go over that briefly. So pictures like this could be on a test. Obviously, you got a non-precision on the left, and if you look at this picture, this is the jar, and then that cloth acts like a wick. And the dial here, right here, it looks like a little knob. You can open it, and if you open it, kind of like an old oil lamp, it'll allow more liquid to wick up. It'll increase the delivery of the anesthetic gas, and if you turn it off, it'll squeeze some of that liquid out of the wick and you won't deliver. And I know we haven't done machines, but these two tubes are the inhalation and exhalation tubing. So this is the circle. When a patient inhales, exhales, and they inhale and exhale in a circle. So whenever an animal inhales, they're going to draw oxygen through this jar, pick up anesthetic, and bring it to themselves. That's why this is non-precise, because a patient's respiratory rate can affect, you know, again, if they, the more they breathe through this jar, the more anesthetic they're pulling to themselves. That's why if they double their respiratory rate, they're in effect doubling their concentration. Now, this is considered, this is why non-precision is also called a VIC. This jar vaporizer is within that circuit or circle, and that's why the respiratory rate affects it. Now, this is your precision vaporizer, which is considered a VOC, out of circuit. And this inside has a temperature control mechanism, because remember, temperature affects how something turns into a vapor. If I told you an agent, you know, is in a cold environment versus a warm environment, you guys all properly said the warmer it is, the quicker it turns into a vapor. So temperature affects the vapor. So that's why a precision vaporizer has a temperature control. This is just a jar. If you were doing this out in a barn, in a cold barn, it's going to vaporize slower than if you were, you know, in a barn on a hot day. I mean, so there's not really a temperature control with this as there is with this. Here is kind of a diagram that explains the circle system, okay? And these little red arrows, is the red arrow going down is going to the patient. The other arrow is when they exhale. So what happens is oxygen comes in through the vaporizer, goes into the circuit, they inhale, and then they exhale. But the vaporizer out of circuit is out here. So when a patient 5 breaths a minute, 20 breaths a minute, 40 breaths a minute has no bearing on the anesthetic concentration. If you set it at 2%, the patient's getting 2%, regardless of what they're breathing. The difference here is your vaporizer is within this circuit. So respiratory rate and drive, how deep are they breathing? How strong are they breathing? Does have a direct effect on your concentration. So again, precision vaporizer is out of circuit, in circuit is called non-precision, and it's non-precision here. The key is they were used because the old agents that we used to have had a low vapor pressure. Methoxyfluorine had a very low vapor pressure, meaning it didn't want to readily, it was considered non-volatile, and it didn't want to readily turn into a gas. So it was stable in the jar, exposed to air, exposed to oxygen. The problem is when they made iso and sevoflurane is they have a high vapor pressure, are volatile, meaning they need a little more control. They were not appropriate for the vaporizer in circuit, the non-precision type. So that's kind of the way to understand. And then, you know, controlled amount. I talked about the fresh gas flow. You know, the temperature affects, respiratory rate only affects a non-precision vaporizer. Again, respiratory rate doesn't affect. Now, I did make a note yesterday that, oh, let me get to the picture. No, let me go back. There we go, that's the picture. So this picture here, letter A, if you look, this is the inlet to the vaporizer. And at this point, we just have oxygen. Oxygen is coming to the vaporizer. Letter C is your little like open close valve. And when you push it down and turn the dial, this vaporizer is set at 2%. So, and then at letter B, this is the outlet of the vaporizer. At the outlet is the very first spot where you have oxygen and inhalant. You have mix, okay? And then letter D here is your fill indicator window. And that tells you how much liquid you have. And again, you want it somewhere, it could be in the middle. Most people, when you fill it in the morning as a student, part of your job is to go in and fill your vaporizer and check your machine. There's a little bar here at the top, it's hard to see, but there is a full line. You don't want to go over that because you can't overfill. And if you overfill it, backflows inside the machine and can cause overdose problems. It can mix, it can damage some of the internal parts. So you definitely want to be cautious when you're pouring. And then letter E is, that's where you fill. That's the port where you fill the vaporizer. You just untwist that knob, take it off, and then you pour your, and you just have to be careful when you pour. Now, again, I told you guys, if you spill, you want to try to cap this real quick and leave the room. You don't want to stand over a spill because, again, isoflurane can reach up to 30% just out in the environment. If you stand over it, you can get dizzy, you could potentially pass out. So if you spill it, the best thing is you can try to throw a towel or something on it. It's going to vaporize very quickly. So you just want to be out of the room for about 10 minutes, 15 minutes, maybe fan something, you know, or have a fan or open a window if that's possible to try and dilute that out. You just don't, you know, want to pass out. It can happen. So, okay, I talked about, and don't tip the vaporizer too. Again, that can cause damage. If it tips too far, it can cause it to backflow into the parts in the vaporizer. Also, if it falls over, you probably need to get it checked, you know, send it off to the manufacturer. A lot of clinics, you know, I said have some support. Okay, let me see if I can pull up. Oops, that's not what I wanted. Oh, yep, that's what I wanted to do. Well, I only have about 5 minutes, so I'm probably not going to pull this up. Now, the other part, like I said, of the test is the induction agents, which you have propofol, etomidate, alfaxin, tilazol, Ket-val were the primary induction agents. Now, if you had a perfect world and you had all of those drugs, there's definitely pros and cons. But, you know, remember, propofol, alfaxin have a shelf life. Alfaxin's controlled. Tilazol is good for IM induction. You know, you can go in, and I will probably close your old test tomorrow at 9 a.m., but you can go back in and review your induction test. As far as monitoring parameters, you know, I talk about tachycardia and bradycardia, and, you know, what pre-med did I tell you to be most cautious of, speaking of bradycardia?
Dexdomitor?
Yes. So again, that's about the only agent that is going to cause that rapid, you know, unless you had a vagal stimulation. But really quickly, if the heart rate drops, you can look at your anesthetic record and your dog either got dexdomitor or did not. So more than likely it's probably from the dexdomitor. Now they can be deep. You may have to turn down your inhalant. But I think what I've told you also, and also brachycephalics. So when I've used brachycephalics in my examples on tests, my main concern is airway control. You know, first of all, they usually have smaller tracheas for their body weight. They usually have elongated soft palates. They have sometimes what are called everted saccules, which are in the back of the airway. Stenotic nares, which just means they have narrow nasal openings. They just have everything working against them to breathe. So if I'm going to anesthetize one, first of all, my primary concern is getting rapid airway access. And I, you know, on my example on that test, I talked about, well, if I have a drug like Ket-val and they can still swallow, anytime an animal can retain their swallow reflex, if you go to put a tube in their throat, a lot of times they will fight you a little bit more. Well, they're already difficult to intubate when they're completely asleep. It's a challenge. But then I take a dog that's a challenge on top of he's fighting me. So again, how do I apply that to my agents? What agents do I have that give me rapid airway access? Well, propofol and alfaxin are going to be my top two because they produce a quick induction, a smooth induction. They don't retain their swallow reflex. But if I have tilazol and Ket-val, both are dissociative agents and they do retain swallow reflex. So that's probably not going to be the agent I want to use because I want to get a tube in immediately. And always making sure I have oxygen available. I know where my tubes are, you know. So that's kind of, you approach it from an analytical mindset, is that hopefully everything goes smooth, but you're prepared if things don't go smooth. That's the goal. Oh, and I talked about animals, you know, sight hounds, the lack of body fat affects the agents we use. Animals that are hypoproteinemic, you know, so that dosage, whenever you have an anesthetic dose, it's formulated for a normal protein. And when you have an abnormal protein, like low protein, then we have to adjust the dose. If I have an animal that's hypoproteinemic, do I increase or decrease my dosage mgs per kg?
You said hyperprotein.
Or hypo, so low. If I have a low protein, how do I adjust my dose?
You lower the dose.
Yes, because if a drug is bound to protein, if whatever's bound is not going to go through the capillary and is not going to enter the brain, if you think of it that way. And so some of that drug remains within the blood. Some of it's going to sneak through the free drug. Not all of it binds, okay? Some of it binds, some is free. Whatever's free goes through the capillaries, goes in the brain, okay? But if we're bound, it stays within the vessel. So if I have an animal that has low protein levels, hypoproteinemia, or they're hyperproteinemic, then that means theoretically there's more free drug available. So lower the dose. And my mantra is you can always give more. If you give a lower dose and then your patient's kind of looking at you like, I'm not going to sleep, then you can give them some more, So what other questions do you have as far as for the test or anything? On a side note, hang on one second.